Okay, so today we are talking about chapter 10, which are the sexual dysfunctions, paraphilic disorders, and gender dysphoria. And if you're anything like me, you're looking at that going like, well, that's like a lot to cram into one chapter, and why are they all here together? Because they're very different things. And you're right. I think the issue at hand is they are all loosely related to sex and genitalia on some level, and that's why they've all been put together. But we will be talking about each of them as separate categories. So we will be talking about the sexual dysfunctions, the paraphilic disorders, and then gender dysphoria. And in fact, gender dysphoria this year, because we have, excuse me, 2 classes for the topic, we're going to save gender dysphoria for our second class. So today we're going to really focus on the dysfunctions and the paraphilic disorders. And then we'll go ahead and talk about gender dysphoria. So I've pretty much already given you a bit of the overview, but when we're talking about the sexual dysfunctions, we're talking about disruptions in sexual functioning despite good psychological health. So as you'll see, sometimes people get into a little trouble in the boudoir, and we don't really know why. Like, physically, everything checks out okay. Psychologically, there's no depression, anxiety, because we know that those other disorders certainly could play a factor. But so these are cases where there's no physical reason for them to be encountering this dysfunction, and there's no psychological reason in terms of another disorder. So we assume there's something else going on a psychological level. The paraphilias encompass sexual attraction to unusual activities or objects. And then finally, gender dysphoria, of course, is talking about people who believe they are of the opposite sex. They do not view themselves as aligning with the gender they were assigned at birth. And so, like I said, everything here is loosely related around sex or genitalia. That's why it's all put together in the same chapter. But again, the 3 different types of disorders are in fact quite different and unrelated to each other. What I'm going to have you do now is watch a 12-minute video. So it's a 12-minute video. This is something that I typically show in class. And it's just to get us a little warmed up and on the same page. And so you'll watch that and then come on back. And I'll note a couple of the differences between that and what we're going to cover. Okay. So into the sexual dysfunctions. Well, the first thing actually I want to note about the video, is that the presentation of Masters and Johnson that they do in the video is a little bit different than what you're going to see in the textbook and what I'm going to talk about in class. So, of course, in an exam situation, I'm right and the YouTube video is wrong, but I don't anticipate that this is something that would come up on an exam, so don't sweat it too much. So when we're talking about the sexual dysfunctions, we are talking again about a range of problems considered to represent inhibitions in the normal sexual response cycle. And essentially, many of them are thought to have underlying psychological components. But before we can get into the dysfunctions, we have to actually talk about what's the normal sexual response cycle and how do we know about it? And that's, again, part of the value of having had you just watch that little video. You heard about Kinsey, you heard about Masters and Johnson, and again, what Masters and Johnson did was they had healthy adults come into the lab and have sex while hooked up to monitors in order to understand what is happening and in order to basically plot out the human sexual response cycle in a more scientific way. Okay? So when they originally proposed it, this first phase wasn't there. Kaplan added this phase in 1974, which is what's known as the appetitive phase. And the appetitive phase is that initial pleasure or desire, right? So that initial interest in someone that they are interested. So there's really not a whole lot going on at this stage, but it's like, hey, right? You're kind of looking at someone, you're looking at maybe your partner, maybe a stranger at the bar, maybe you're wondering what's going on under that person's mask, right? Like, these are strange times, people. So that's just that first little bit of excitement or interest. Then we move into the actual excitement phase, and it's during this phase that participants are engaged in sexual activity and excitement is building. And again, when I say sexual activity, I'm not necessarily meaning penetrative intercourse. It's any sort of sexual activity. So it could be kissing, it could be fondling, it could be you let your imaginations run wild. But it does not have to mean penetration. It doesn't have to mean sexual intercourse. There's a whole menu of options that fit under the category of sexual activity. So at this point, what we're starting to see is increased blood flow to the genital regions, right? So we're engaged in some form of sexual activity, and our body is responding by sending extra blood to our genitals. Then we have the orgasm phase, which I probably don't need to elaborate on all that much, but essentially this is the plateau of the sexual response cycle. And then we have the resolution phase. And in the resolution phase, we're basically just sitting there basking and feeling pretty good, right? It's that post-orgasm, like, that's good, it's good, right? We're in a good place. And it's the period during which the body comes back to normal or resting state. So heart rate starts to decrease, breathing rate starts to regulate. And then finally, what we see happening after that is what's known as the refractory phase. And the reason I have that in parentheses is because this also was added after the fact, and also because the refractory phase really only impacts males. So this is a brief period during which males cannot become erect again or cannot engage in intercourse. So they can still engage in other sexual activities, but it might be frustrating for them because they cannot achieve an erection again at this point. The refractory period is typically brief, and again, women typically do not experience that. Okay. Now, it's important to remember that for all sexual dysfunctions, there is a wide range of what people will consider normal for themselves, or abnormal for themselves, or typical or atypical, okay? Some disorders are only distressing to the person experiencing it, or they're not. Sometimes it's the partner who's distressed by the person experiencing the disorder, even though the person with the disorder is not actually distressed by it. So that could happen when they have a partner who has a higher sex drive or who's more interested in sexual activity. And so you have a mismatch there. And that is often what drives people to a psychologist's office to address any of these issues. Sometimes it is their own sense of like, okay, something isn't working here for me. But sometimes it actually comes up in the context of couples counseling or marriage counseling, where one partner has a higher sex drive or more sexual desire than the other one, and that's a mismatch and obviously could lead to conflict. So now we're going to get into the actual dysfunctions, and these loosely, all of the different groups of dysfunctions will loosely map onto one of the phases of the human sexual response cycle. So the desire disorders loosely map onto the appetitive phase, right? So we think about the appetitive phase as that initial interest, so that initial desire, and so it kind of makes sense that the desire disorders would link there. So we have male hypoactive sexual desire disorder, which is exactly what it sounds like, deficient or absent sexual fantasies and urges. So this is a male who does not desire sex, which of course in our society is like, what the hell is wrong with you? Because our society basically says men should be thinking about and or having sex all day, every day in order to be happy, which there's so much wrong with that, but we'll leave that for discussion. I'm not going to get on that soapbox right at this moment. So this is deficient or absent sexual fantasies and urges for men. And likewise, we have a female sexual interest arousal disorder. And with women, we go a little further in classifying it or defining it as active avoidance of nearly all genital contact with another person. Okay, so women who experience sexual interest arousal disorder basically are like, they're not looking for sex, they don't want to be touching, they don't want to be bumping genitals with another person, they just want to be left alone. Now, when we think about these disorders, males will likely be more distressed than females. And again, part of that is our society says that men should be thinking about or having sex all the time. Women, of course, we have this double standard. Women are, only recently have women really come into a place where they can talk about being sexual beings without being looked at funny, although in some parts of the world they are still looked at funny. Because for a long time, men were supposed to be out there enjoying sex. The question is with who? Because women were only supposed to be having sex for procreation purposes. So it's like, so like blow up dolls? Like who are the men supposed to be having sex with? That's the thing I've never fully understood. But that's a story for another day. As we then move into our sexual arousal disorders, these loosely map on to the excitement phase. And we really only have one disorder here to talk about, and that's erectile disorder. And erectile disorder is something that, as the name would suggest, only impacts men. And it's a failure to attain or maintain an erection. Erectile disorder is something that's going to increase with age. So as men get older, it's more likely that they will experience this, possibly occasionally, possibly regularly. And erectile disorder, interestingly, for a long time was something like men would not talk about. And now, like, you watch a hockey game and there's ads for Viagra around the rink, right? And like Mike Ditka, who is like a famous NFL football coach, has done commercials for Levitra. And so basically they're saying like, hey, guys, no big deal. All guys experience this sometimes. And hey, here are these pills that are going to help. And so it's really interesting that somehow there was this shift. And again, I think it goes with this notion in society that men should be sexually active to say like, can't get it up? No problem. Here's a pill. And it's like destigmatized it and demystified it and made it very routine, which is so interesting to me for so many reasons. And again, in class, live, I would be getting out a soapbox right now, putting it down, standing on it to talk about what I perceive to be one of the very greatest injustices in our healthcare system when it comes to sexual activity, which is that women sometimes struggle to gain access to contraception. Pharmacists are legally allowed to not fill a prescription for contraception if it goes against their religious beliefs. They do have to refer you to someone else who will. Women have to go see physicians and in order to get birth control, and depending on what's going on, they may have a doctor who's more puritanical who isn't comfortable prescribing it to them. Now, contraception, birth control pill, allows women to actually enjoy sex without worrying about getting pregnant if they're taking it regularly as they should. And yet we have a problem with that, and we limit access and we make it difficult. Men who can't get it up can go get a pill to enjoy having sex. No problem. Are you seeing what I'm seeing? Are you connecting the same dots here? So again, normally I would soapbox on this for a little bit longer, talk a little bit more about it, but I just want to put that out there that as a society we say, hey, guys, you can enjoy sex. Hey, ladies, not so much. We're going to shame you if you enjoy it. Okay, soapbox rant over for now. There's always more. In this chapter, there is always more, I gotta tell you. Okay, so on to orgasmic disorders, which of course would map onto the orgasm phase. And we have 3 disorders here. We have female orgasmic disorder, male orgasmic disorder. I'm not sure why we can't just have orgasmic disorder without needing to specify female, male, but we do. And premature ejaculation, which also is going to affect men, not women. Now, in female orgasmic disorder, it is only going to be diagnosed if a woman is distressed. So keep that in mind because I'm going to come back to this point in just a second. And essentially, this is a persistent absence of orgasm. So we know from the human sexual response cycle that after we get excited, we should achieve orgasm. That's sort of the plateau. That's the bells are ringing, the birds are whistling moment. And then, of course, we come back down from that. And female orgasmic disorder is diagnosed when there's a persistent absence of orgasm, but only if it's distressing to the woman. Here's the thing. A lot of women are not terribly distressed by a lack of orgasm because unlike men, who typically will experience orgasm every time they have sex, every time they get into that human sexual response cycle, they will achieve orgasm. A lot of women do not consistently achieve orgasm. So a really important piece of understanding female orgasmic disorder is always going to be asking a woman about her orgasm base rate, so to speak. So a woman who normally achieves orgasm 8 out of every 10 sexual experiences, if she drops down to a 5, she may be quite distressed by it because she regularly has orgasms, she enjoys them, they're pleasurable, and now there's a drop and it's like, ooh, what's going on? But another woman may have a base rate of 4 or 5 and drops down to 3 and doesn't even notice because it's a 50-50 thing to begin with. So we're in a slump, we'll get out of it, okay? So that's a really important piece to consider is that, and this is an area where, again, I think a male partner who is tuned in, or a female partner for that matter, actually, a partner, let's just say a partner, who's tuned in to a female partner who is aware if she is or isn't achieving orgasm may notice like, hey, like, am I not doing it for you anymore? Like, what am I doing wrong? How do I get you there? And the woman might be like, oh, like sometimes it just doesn't happen. Like I'm stressed or I have a backache or I was thinking about what to make for dinner because really whatever, right? Like sometimes you kind of just phone it in. So he or she, so the partner may be more concerned. They may be thinking like, what am I doing wrong? How am I causing this? How can I make this happen? But the person who's actually experiencing the lack of orgasm is like, it's okay. I'm not bothered by it. If she's not bothered by it, we don't diagnose it. Male orgasmic disorder is when men have difficulty ejaculating. So again, ejaculation happens as part of orgasm for men. So if a male is engaging in sexual activity, is going through the sexual response cycle, reaches the point of feeling like they're going to orgasm, but then can't ejaculate, that's male orgasmic disorder. And then premature ejaculation, of course, is when they ejaculate too soon. If you need a reference point for that, go ahead and watch the movie American Pie. You'll be all set, okay? But I don't think you really need a reference point for that. I think it's pretty self-explanatory. And again, these disorders are likely to be more distressing for a male who cannot ejaculate or a male who ejaculates too soon is more likely to be distressed by it than a woman who maybe isn't having as many orgasms as usual. But again, for a woman who consistently reaches orgasm, she might be quite distressed by it. And that's okay too. If you're gonna have the sundae, you want the cherry on top, right? Okay. Then we have our sexual pain disorders. And these, of course, don't really match onto any phase of the sexual response cycle, but loosely we could sort of put at stage 4, which is resolution. Loosely, though, I'm saying. And the name is just brutal. Genitopelvic pain penetration disorder. Yeah, and it's meant to be a little more descriptive. The former name, so this is 2 different disorders that have been collapsed into one. The old names were dyspareunia and vaginismus. So somehow this is a step up, even though it doesn't seem like it because it's a really weird name. Genitopelvic pain penetration disorder. And essentially, so first of all, this is specific to females, okay? And And this is difficulties with penetration of any kind. So this includes tampons, fingers, penises, dildos, doesn't matter. You want to insert it, it is not going in. Or pain with intercourse. Okay, so it's either difficulty with penetration or pain when the person does have intercourse. It can make it difficult or impossible for a female to have a gynecological examination. So that makes it even, I mean, in some ways it's confirmatory in that if a doctor can't do an examination, like, okay, this is what this disorder is, but it also means that it's hard to know if there might be an anatomical reason for this to be happening. But again, this is something that is likely going to get a woman's attention. Certainly pain with intercourse. Intercourse is not supposed to be painful. And also, obviously, if a woman cannot, like, essentially the vaginal walls spasm and, like, close up, so it's like, thou shalt not pass. And that's for, again, whether it's a penis or a tampon. And I'm going to crack up because Ian is cracking up right now. And it's really hard not to when there's one person in the room laughing. Okay, this takes us to reflection question number 1, which is, do you think the sexual dysfunctions are real psychiatric disorders, or do you think we are pathologizing the range of human sexual activities? And go ahead and explain that. Remember, 6 sentences or less. Okay, so now that you've had a chance to reflect, let's come back and talk about treatment for these disorders. Couples therapy may be an important component in addition to individual work, because if one partner has a sexual dysfunction, it inevitably affects the other partner, right? Like, you can't have, let's say, and again, I'm going to use male having the dysfunction simply because a male is more likely to seek out treatment. But if you have a male who has erectile disorder and cannot maintain or even attain an erection, well, his partner is going to be bothered by that, right? If the partner is actually interested in sexual activity. Maybe not. Maybe the partner's like, woo, I get a break. But typically that's going to have ramifications for the relationship. So while individual work might be helpful, couples work may also be helpful because of how the dysfunction or the disorder impacts the relationship. And so some of the treatment actually does incorporate couples. So from a psychosocial perspective for treatment, one of the big things that came out of Masters and Johnson's work was what they called sensate focus. And the idea behind sensate focus is you have the couple agree to take the idea of intercourse off the table. So there is going to be no intercourse. There's going to be no pressure surrounding intercourse. We are not having sex. It is just not going to happen. And instead, partners are given explicit directions to not engage in the sexual intercourse. So that's the first part, but rather to explore what each person likes and doesn't. And so basically to touch each other, to caress each other, to kiss each other, to find out what does stimulate the partner and also what doesn't. There's nothing worse than someone trying to get romantic with you and you're like, yeah, no, this isn't doing it for me. Like, this is all wrong. So as an example, you could have a couple, and I'm gonna be heteronormative here and just use a male and female couple. But again, it could be any couple. It could be a heterosexual couple, no problem. Homosexual couple, no problem. But let's just say we have a male who is very, very breast focused. For him, his partner's breasts are what stimulate him. And he wants to touch them. He wants to kiss them. He wants to be all over them. But let's say the woman actually finds that someone kissing her breasts or nuzzling her breasts is really not something that she enjoys. So he wants to do that in order to stimulate himself, but what he's actually doing is turning her off in the process. that's going to be a mismatch that's going to lead to problems further down the road in terms of intercourse and enjoyment. So what sensate focus says is like, take everything you think you know and erase it. Start with a blank slate. This is your partner. Touch him or her. Listen to him or her. Find out what he or she likes. Find out what he or she doesn't like and stop doing that. Even if that's what you like, if they don't like it, if it's a turnoff, you got to stop that. And then what often happens as couples are getting all sorts of handsy and figuring out what they do and don't like, they end up having sex even though they've been told explicitly not to, right? But what sensate focus does is it emphasizes communication between the partners. So it's a very clear, you say, yes, I like this, or no, I don't. And it also takes that pressure off of intercourse, which has been problematic. And as we know, oftentimes once we take the pressure off of it, it can happen naturally and be more enjoyable. Okay, so that's sensate focus. Then we have the squeeze technique. The squeeze technique is used to treat premature ejaculation. And once the male has achieved an erection, the partner squeezes the penis where the head meets the shaft to decrease arousal. And this gets repeated until the point where the penis is inserted into the vagina. And then you release. And hopefully then ejaculation happens when it's supposed to, instead of happening too early. If premature ejaculation still happens, you just start again. So this is really what it sounds like. Probably not the most pleasant. And again, this is till the penis is inserted. I said vagina before, but it could be anus as well, again, depending on the situation. I will just say I try my hardest to shift away from exclusively heteronormative language, but it's really hard because I learned and trained in almost exclusively heteronormative language. So please bear with me as I try to make this shift to be more inclusive. And then we also have masturbatory training. And this is used primarily for orgasmic disorders, but it could also be used for the desire disorders. And essentially, what we're doing here is telling people to explore their own damn bodies. Not quite like that, but to say, listen, like, do you even know what you like? Do you know what you find stimulating? Are you even comfortable with your body? And so for people who are having trouble achieving orgasm, the thought is you need to slow it down, you need to go solo, you need to figure out what you like and what feels good for you, and not worry about pleasing a partner, not worry about what your partner thinks about what you find pleasurable, but for you to reach a pleasurable peak, you have to know what is actually pleasurable. So the idea here is that, or the goal here is to get comfortable with masturbation in the hopes that that will then create better conditions for orgasm to happen. Vibrators are often prescribed, if you will, as part of this. So you could imagine that for someone who is having difficulty achieving orgasm, who is bothered by it, and who seeks out medical attention and is then basically told, well, you need to masturbate. It's like, what? I'm sorry, what? And I actually had this happen with a client. She was young, she was sweet, she really wanted to be having sex with her boyfriend, but she really wasn't enjoying it. She wasn't achieving orgasm, she was having pain. And as we talked about it, I realized a couple of things. Number one, she felt like her parents would highly disapprove. She was a university student. When she would go home on weekends, she would hide her birth control pills because she didn't want them to find it and know that she was sexually active. So there was all sorts of messaging there internally. But the other thing was she really didn't know her body at all. And so at the time, I was a trainee, I was an intern. And so my supervisor was the one who said to me, well, you need to basically have her start masturbating. And I'm like, this like scared little field mouse of a client, you want me to basically look at her and say, you have to masturbate? She's like, yep. And I'm like, can we have a gentler approach, please? And she's like, sure, recommend a book that will teach her how to masturbate. And I'm like, oh, okay, I could do that. And so there's this book, and normally in class, if we were in class, I would say, it's in my office. You're welcome to come by and look at it. And I've actually had a few students over the years come by to take a peek. It's called For Yourself, I think. Yes, For Yourself. And it's basically just a small little paperback. But it basically is a book about encouraging women to explore their own bodies and figure out what they do and don't like. So that is one of the psychosocial treatments, masturbatory training. Now, let's get into the medical treatments. And here's where things can get kind of fun and interesting. So, I already talked about erectile dysfunction medications, Cialis, Levitra, Viagra. Those are pretty simple. Men go and get them. They take them. They're happy. End of story. Then we have both penile implants and vacuum device therapy. And I used to just talk about these, and then last year in class, one of the students was like, okay, like I'm having trouble like really picturing this. And I'm like, sure, no problem. And I pull up Google and boom, and show images. So this is your warning again. I've told you before, and I will tell you again, these lectures are meant for adults. If you are watching this around children, or if you have children who use the same web browser as you might want to clear your history after you click the link. But a penile implant is exactly what it sounds like. I'm not doing anything crazy here. Oh no. So, we go right to the source of the Mayo Clinic to look up penile implants. Again, you want to make sure your information for something like this in particular is going to be fairly accurate. And here we go. And just for funsies, there we go. Now you can really see it. So what ends up happening is there's a rod that is inserted and surgically inserted into the penis. There's a little reservoir, and there's a little pump bulb that also has a release valve. And so when you know, poor Ian is dying again, especially because I've made the image so nice and large to talk you through it. And so you can see that the rod is actually semi-rigid, so when the penis is flaccid, it's fine, it just does its thing. But then when you pump it, so the pump is there and you pump it up, the fluid comes in from the reservoir and boop, now you have an erect penis. And you could have this as a 3-piece or a 2-piece. The 2-piece, the release valve is down here. There is no reservoir, so to speak. But you just pump and it's just air and boom, same thing. So again, it's semi-rigid. And there you go. Oh, there is a fluid reservoir and pump unit in the scrotum. So there you go. So that's our first one. I'm just going to shrinky-dink this. This is kind of hard. I'm at a very awkward angle here. Go back into this and then get our vacuum device therapy. Whoops. Oh, come on. There we go. And show you that. Well, also, Mayo Clinic. So this is the pump. So the pump is used to draw blood into the penis to create an erection. You then place a rubber ring around the base of the penis to maintain the erection. Easy peasy. And totally discreet and totally mixes into foreplay. Super easy. So obviously the vacuum pump is going to be a little bit more awkward, but the vacuum pump doesn't require surgery. The penile implant requires surgery. So you got to make your choice there. Okay, we're going to move on from this, which Ian is very grateful for. We're going to go back in here. Oh dear. Okay, so you have those links there too if you want to spend a little more time with them. And here we go with reflection question number 2. Were you surprised that I showed you penile implants and penis pumps in such detail? If yes, why? If no, why not? And my note here to you is you will need to learn to become comfortable with things that make you uncomfortable if you are planning to work in human services, psychology, or healthcare. You have to be able to use the terminology. You have to be able to say it without giggling, right? Ian's off the hook. He's not in this field. He's allowed to giggle. But for the rest of you, it should be okay for you to walk into a colleague's office and they have a picture of a penis pump on their screen because they're putting together a presentation about erectile dysfunction. Okay? You have to learn to you can't giggle like a schoolgirl every time you have to say penis or vagina or anus or sexual intercourse or orgasm or premature ejaculation, right? They're just words. They're just words, and you need to get comfortable with the things that make you uncomfortable. So reflect on this, and then we'll come back and move into the paraphilias. So we're now into the second part. We're going to shift gears. We're going to sort of like shake all those images of penises out of our heads, and we're going to shift into the paraphilias. And so again, the paraphilias are sexual attraction to unusual activities or objects. Okay, it's only considered a disorder if there is distress and impairment or harm or the threat of harm to others. So there's a couple of parameters. Usually we say, okay, if it causes distress or impairment, it's a disorder. But as we go through the paraphilias, you'll see with some of them that people may not be distressed about them, or it might not be impairing them. But it may be causing harm to someone else, in which case maybe it is a disorder. For some of them, there's no distress, there's no impairment, and everybody goes home happy. Well, then there's no disorder, okay? So that's something we have to keep in mind. We also have to keep in mind that many of these paraphilias are in fact illegal. But also keep in mind, things can be against the law and not necessarily be a disorder. Getting in trouble with the law, though, would be a sign of causing impairment. So that would be crossing that threshold of this is just something weird that gets me off to, ooh, now I'm facing consequences, so now it is causing some sort of impairment. So we're going to go through these basically one at a time and take it from there. So the first one is frauderistic disorder. So people with frauderistic disorder become sexually excited by touching an unsuspecting victim, sexual touching of an unsuspecting victim. And so frauteurs, as they are known, tend to operate in crowded places. So if you've ever been on a really packed C-train car and you think you might have felt something weird in your back, yeah, you probably did. And the person who is the frauteur, the person with frauderistic disorder, most likely did it just before pulling into a station where he was able to jump off the train, so that by the time you turned around to look at who was rubbing up against you, he was gone. So crowded trains, crowded buses, crowded areas are where frauteurs do their thing, because they only become aroused if it's an unsuspecting victim. So if you were to say, hey, I'm here for the touching, they're like, no thanks. That's not exciting to them. That's not arousing to them. You have to be unsuspecting for them to do it. It can be very difficult to catch, very difficult to actually catch a frauteur in action. Just last year, though, there was a Law & Order SVU episode featuring frauteurs on the subway. So if you are looking for something to watch, you can look that up and at least sort of see a frauteur or several frauteurs in action, if you will. Fetishistic disorder is when the person relies on an inanimate object, typically, for arousal. So it may be women's shoes, so a male, and again, males overwhelmingly are represented in the paraphilias. We don't tend to see as many women experiencing paraphilias. So a male might only be aroused if he is fondling a woman's high-heeled shoe at the time. That's what he needs in order to become aroused. Sometimes it's specific clothing as well. That could also be a fetishistic object. Voyeuristic and exhibitionistic disorder. So our voyeurs become aroused when watching others engaging in sexual activity or in a state of undress. So again, typically women, but sometimes men, when they are naked, when they're changing or just getting in or out of the shower, that's what a voyeur wants to see. But again, it's the person needs to be unsuspecting and not know that they're being watched. So porn, for example, is not arousing to a voyeur because obviously the person making the pornographic film is aware of what they're doing. So having someone watching them engage in sex or getting naked doesn't really do it for the voyeur because the person knows that that's what people are going to be watching. So this is more of what used to be called a peeping Tom. And again, this kind of straddles that line of, like, if someone's looking in your window and you don't know that they were looking in your window and it gets them off, but if you find out, don't you kind of feel gross? And then we've heard about cases, there was a case a couple of years ago in Calgary where an employee at one of the City of Calgary owned and operated pools had installed video cameras in the women's change room and was getting footage of that. It's happened in clothing stores and change rooms as well. People set up undetectable video cameras and they take pictures. There was also, actually a couple of years ago, there was someone who was found dead in the wall of the women's washroom down at the core, I believe. And the thought was he may have been trying to be watching and then got stuck in like the air shaft and died. So careful with your voyeuristic intentions. Okay. Yeah, and upskirt photos. That's the other thing. That's the other new thing for voyeurs is they take upskirt photos. Exhibitionistic disorder. Exhibitionists become aroused when exposing themselves, particularly their genitals, to other people. They are traditionally known as flashers. When I was in high school, when I was in grade 7, my high school was across the street from a park, and I remember for gym class, we were outside running, like for cross-country running, in the park. And as we were coming, like just around the last bit before coming down the hill to go back to school, there was literally a guy in a trench coat, and this was an all-girls school. We were in grade 7, and as we ran past, he opened up, flashed us. That was the end of the cross-country running unit at our school. All running was then contained to laps in the school gym. Because, yeah. But for him, like, good planning, dude. The park across the street from an all-girls school? Yeah, you got it made. So that's exhibitionism. Transvestic disorder. Transvestic disorder is when a person cross-dresses for the purpose of arousal. So there are some people who cross-dress just for funsies, okay? Just because it's fun. It has nothing to do with sex. It just has to do with dramatic and fun, and it's fun to imagine if you were someone else. Transvestic disorder is when someone is cross-dressing in order to become aroused. So they do not become aroused unless they put on women's underwear. And it might escalate to actually putting on women's clothes. This is not somebody who wants to live as a woman. So this is not someone who's transgender. This is not someone who just wants to be a drag queen for fun. This is someone who becomes sexually aroused by putting on women's clothing. Now, I'm often asked, again, typically it's males dressing in female clothing. And part of it is in part because women can wear men's clothing, right? Like, I'm standing here today in a pair of jeans. 300 years ago, if I was a woman wearing jeans, people might have suspected that I had transvestic disorder and found wearing jeans arousing. But now, women are allowed to wear pants. We have been for a while. It's something that we do, and it's not because it's arousing, it's because it's comfortable. So, because in our society we allow women, as a society, we allow women to dress in what used to be stereotypically male clothing, we're less likely to see it. There are some women who may become aroused by wearing men's clothing. They may, but even that, Now women can essentially get like boy cut underwear or like boxer briefs for women. So it's like, once it's not taboo anymore, what's the fun, right? So again, this is cross-dressing for the purpose of arousal. And there we go. Now, sexual sadism disorder and sexual masochism disorder. This is these two, they go together, which is why I'm describing them together. And this is a case where if you have a sadist in a relationship with a masochist, everybody goes home happy and there's no disorder. Okay, so a sexual sadist becomes aroused or derives sexual gratification from inflicting pain on others. So again, a sadist is going to become aroused or get sexual gratification from inflicting pain on others. On the flip side of that, a masochist becomes aroused if they're on the receiving end of that pain or humiliation. So, sadist, masochist, they go together like peanut butter and jelly. Everybody goes home happy. The sadist gets aroused by treating the masochist like crap. The masochist gets aroused by being treated like crap. No one gets hurt, no one's upset, no one's distressed, no one's impaired. We're not diagnosing them. The problem is when you have a sadist or a masochist in a relationship with someone who is neither a sadist or a masochist, then that's when things get, you need to go talk to someone. That's just weird, right? So if a sadist is in a relationship with a non-masochist, and maybe they start slow, maybe they're like, can we just like incorporate some dirty talk, right? And then it evolves to actual like humiliating talk and maybe even a little bit of physical pain. And the partner's like, I did not agree to this. This is not okay. And if this is what gets you off, you're sick. You need to go talk to someone. And the sadist is like, oh, my last partner was okay with it, but your last partner was a masochist. So yeah, they were. Similarly, a masochist in a relationship with a non-sadist who's like, please degrade me. Please hit me. Please don't just pull my hair in a teasing way, like yank that hair so I cry. It's like, no, I'm not going to do that. What is wrong with you? So the distress and impairment typically comes from being in a relationship. Two jellies don't go together. You need peanut butter and jelly. You can't do jelly and like butter, right? Like that's not a good sandwich. You need peanut butter and jelly. So you need your sadist with your masochist for everyone to go home happy. Otherwise, we might see distress and impairment, particularly from the other partner as well. And then we have pedophilic disorder. And pedophilic disorder is, of course, when people are aroused by prepubescent children. These are what we typically refer to as pedophiles or pedophiles. Clearly acting on this urge is a violation of the law, both in terms of physically acting on it and acquiring images, so like child pornography. We're concerned about this even if the individual isn't concerned about it because of the implications and the potential for harm to befall children. There are arguments made that child porn is actually like a form of like risk management in a way, that by allowing pedophiles to have access to child porn, that prevents them from actually engaging in sexual activity with children, but that is not really supported. And it's still the exploitation of children. There have been some attempts to make very, very realistic child porn using artificial intelligence. The problem is, where's the line? So if you make it realistic enough that the person who enjoys child pornography thinks it's an actual child, that's still a problem, right? So even if someone who is a pedophile is not concerned about their behavior, we are very concerned about their behavior, because whether it's through porn or actual sexual touching, sexual activity with a child, there is harm to children being done, because the children in the pornography are being exploited and hurt doing that. What's interesting, though, is that this even though this is in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, this cannot be used as a mental disorder in court, right? So someone who is a pedophile, Someone who engages in sexual activity with a young child who is charged with the crime cannot use this as not criminally responsible on account of mental disorder or defect. So that's just something else to keep in mind. Now, it too is more common in men, but it can be found in women. It is rarer in women, but it can happen. Okay. And then we have our other specified paraphilic disorder. And these are other paraphilias that we know of but aren't as common. So they have names, and we know that some people become aroused by these things, but they're not, and we could certainly code for it if they show up for treatment, but we just don't list every single paraphilia known in the DSM. So the rest of them go as other specified paraphilic disorder, things like zoophilia, which is becoming aroused by animals, necrophilia, becoming aroused by dead bodies, and my personal favorite to say, telephone scatologia, which is becoming aroused by making sexually explicit phone calls to unsuspecting victims. Okay, so obscene phone calls, basically. Now, there is a link to a video here. It's a 4-minute video. It is definitely not suitable for work. It's really not suitable for anybody, definitely not children. But I would like you to to please watch it again. It's 4 minutes. And when they come looking for you and you will get a warning that this one you have to agree that you want to watch it, that it is adult content. Okay, so please make sure there are no children around you when you watch this one, for sure, for sure. Okay, well, now that we're done with that little bit of nastiness, and it really is, I wasn't going to torture Ian by playing that one live for you to see and not have to put it in your browser. And in fact, while I have shown that one in class before, I often talk about it, but then just post the link on Blackboard and ask people to watch it on their own. I think sometimes there's some merit in collective experience of watching uncomfortable things, and sometimes it's best to watch uncomfortable things on our own. Okay? Okay, and so just to think a little bit about the treatment of the paraphilias, from a psychosocial side, we're going to look at things like something that's known as covert desensitization. So what we're going to do is we're going to pair arousal with the imagined consequences of their typical object of arousal. So again, this is a case where we would say to someone who is a pedophile, go ahead and get yourself aroused, right? So the way you normally would, so maybe it's looking at child porn, but as you're looking at this child porn, I want you to now think about what the consequences are if you get caught. The idea being that if you're looking at child porn and thinking about getting arrested, thinking about what is done to pedophiles in jails, thinking about your job, your family, everything, that would decrease your arousal and no longer make the child porn arousing to you. Okay, so it's a different type of desensitization. We've talked about it in other ways, but we're very clearly pairing the consequences of the paraphilia with looking at the desired object to take away that power of the desired object, to make it an object of desire. Another option is orgasmic reconditioning, where here we would tell the person to masturbate to their fantasy, so to their paraphilia, to their fantasy, and then just before they ejaculate, we want them to change what they're imagining to something that is more socially appropriate. So again, someone who is, let's say, a voyeur, somebody who likes looking at unsuspecting victims, will say, okay, start masturbating, imagine that you are, creeping up on someone, she doesn't know you're there, she's getting naked, and just as he feels like he's about to ejaculate, we're like, okay, and now imagine that this is your wife, partner, whoever, who's waiting for you in the bedroom, right? So something more appropriate, in the hopes that then as they start to orgasm to the more appropriate material, they no longer need the paraphilic object or material in order to become excited. And then a piece, of course, of psychosocial treatment is going to be also relapse prevention. We have to work with people on recognizing what their signs of temptation are, what are likely going to tempt them to going back to the things they shouldn't be doing, and how to deal with that and engaging in self-control. From a drug perspective, a drug treatment perspective, really the most effective thing here is chemical castration. I mean, actual physical castration works too. Chemical castration, of course, is a little bit less permanent and a little bit more humane. But essentially, what we do in this case is we give men female hormones which will decrease their sex drive. And then if they have a lower sex drive, they are not seeking out these other things to become aroused. And for people who are pedophiles, for people who have tried a lot of other forms of treatment, that is pretty much where they're going to end up. And oftentimes that is a condition of their release from custody. So even after they're in lots of places in the States and some in Canada, we can actually civilly commit somebody because they have this history of abusing children, of sexually abusing children, that every time they go to jail, they receive treatment and they still go out and reoffend. We can actually have a sexual offender hearing for them and to get them declared as a dangerous offender, and then they're held in a civil manner. And oftentimes the way around that is for them to agree to chemical castration because that reduces their sexual urges. And this takes us to reflection question 3, which is, should pedophilia be in the same category of mental disorders, oh, another typo, as the other paraphilias? Oh well, so just read it as I'm saying it. Should pedophilia be in the same category of mental disorders as the other paraphilias? Why or why not? And when you're done reflecting on this, that's the end of this segment.